Morning.
I was talking and I realized my thing was on mute.
I'm sorry, Heaven, I didn't hear what you said.
I said I was talking and I looked down and I realized I was still on mute.
Uh, was the wedding this weekend or just the bridal shower?
It was just the bridal shower. The wedding's not till June 20th.
How'd the shower go?
It was good. We had 3 carloads of presents that we all had to bring to our house, and my whole living room was full, so
Wow.
it was good.
Well, good. Okay, looks like it might just be us for a little bit, so I'm going to go ahead and get started. It's recorded if they want to see it.
Okay.
All right, so we finished up last week. We were still talking about somatoform disorders, and there's one last somatoform disorder that's a little different than the ones we've talked about, and that's hypochondriasis. You've probably heard of someone who's a hypochondriac, and that's what we're talking about here. So have you ever felt a strange pain somewhere, maybe in your foot, or gone on the internet to Google your symptoms, or maybe you go straight to WebMD and use their symptom checker body map? As the results start pouring in, you find that your foot pain could be a symptom of a scary sounding peripheral neuropathy, which another quick Google search confirms is indeed scary. It means you have damage to your peripheral nervous system. And completely ignoring the other potential diagnosis of poorly fitting shoes, you decide you're definitely dying and call up your doctor's office to make an appointment. By assuming the worst about a mild symptom, you exhibited mild hypochondriacal behavior. People with hypochondriasis worry that any symptom they experience signals the presence of serious illness. I got to pause for a second here. It's kind of bothering me. That camera was off center. Some of these people seek medical assistance constantly. Others try to avoid any reminder of illness and are afraid of hospitals and doctors. Most are distrustful of doctors' diagnoses anyway, because if the doctor tells them something other than they want to hear, then they're convinced the physician is just misinterpreting their symptoms. The physician must be wrong. So they typically experience intrusive thoughts about their symptoms. I mean, imagine if with your foot pain, you would think about it at an inappropriate and distracting times, like during an interview or while doing homework. So in this way, they are similar to people with obsessive compulsive disorder. Those with OCD are typically more concerned about catching and spreading disease than they are about actually being sick. All right, so that was the somatoform disorders. Let's go to another DSM classification disorder, the substance-related disorders. A lot of people in American society particularly have a drink now and then, but how do you know if you have a substance-related disorder? Lauren graduated from college and has been living in a house with a few friends. And she's found the perfect entry-level job at a fashion startup and is happy to find that her weeknights are now free from homework and other school-related obligations. Now, while in school, she'd followed what she felt were typical college drinking patterns. She drank a lot on weekends, sometimes Thursdays or Wednesdays, depending on what was going on, and not at all on other days of the week. But now that she's graduated, she's found that she likes having a drink when she gets home from work and maybe also some wine with dinner. She figures this is fine because she doesn't drink as much on the weekends anymore because she has to drive to the bars and pay for expensive drinks. But her roommates notice as time goes on that Lauren's nightly drink glass of wine actually turns into at least 3 glasses of wine, and that they'll often come home to find her seriously tipsy, not falling down drunk, but definitely impaired. They don't enjoy hanging out with her when she's always like this, so often they'll make excuses to go hang out in their rooms instead of with her. They're also concerned because she doesn't seem to have any qualms about driving in this condition. She'll be heading out to visit other friends and they'll have to stop her. They start to think she might have a problem with alcohol, or in the words of the DSM, remember the Diagnostic and Statistical Manual of Mental Disorders, she has a substance-related disorder. And though we tend to refer to any substance-related disorder vaguely as addiction, the DSM actually distinguishes between 2 specific conditions. There is substance abuse and substance dependence. Lauren's situation sounds more like abuse than dependence, but let's go over some of the key differences. Substance abuse is defined as a maladaptive pattern of use of a substance. Basically, that means that someone like Lauren is using a substance, in her case alcohol, in a way that has negative social, legal, or work or school related consequences. And people who abuse substances also tend to continue to use drugs or alcohol in situations where doing so could be dangerous. Lauren's drinking is alienating her from her roommates, and she pulls herself and others at risk when she drives after she's been drinking. So Lauren's roommates decide to confront her about her problem, and they explain their concerns, particularly about the driving, and ask if she'd be willing to try to cut back. Lauren at first says she doesn't think she has a problem, then admits to feeling hungover at work sometimes and agrees to try to cool it for a while. Her friends notice almost immediate improvement. Lauren still drinks occasionally, but not nearly as often as much. She didn't seem to have any trouble cutting back. So it's unlikely that Lauren had substance dependence. Dependence is characterized by all the same things as abuse. People use substances despite negative consequences and in dangerous situations. But a patient with substance dependence is really unable to quit on their own. Sometimes the dependence is physical, and the patient will experience symptoms of withdrawal when trying to stop. And this is more common with some drugs than with others. Heroin addicts are often given another drug called methadone to help them with withdrawal symptoms. And some alcoholics must be supervised in the hospital and monitored for potentially life-threatening symptoms like seizures and delirium tremens, which is a rapid onset of confusion, usually following withdrawal from alcohol use, and usually is also accompanied by a great deal of shaking of the body parts. Substance disorders seem to be inheritable, though the exact mechanisms are unknown. There are genes that are known to influence the levels of the neurotransmitter dopamine in the brain, and high dopamine levels have been shown to make an individual prone to addiction. Drug use itself affects the brain. It may reduce the number of dopamine receptors, thus making it necessary to ingest more of a drug to get the same effect. And we talked about that earlier at the biological psychology. And this is known as tolerance, and it plays a role in addiction and withdrawal. Substance disorders are also affected by cultural norms. Societies that prohibit children from drinking but celebrate adult drunkenness have been shown to have higher rates of alcoholism, and that is true in the United States. Total prohibition of a drug, though, like alcohol in the 1930s in America, seems to result in higher levels of dependence in those who choose to drink anyway. It's almost like being told no, they go overboard. All right, outside of the substance-related disorders, the next classification of disorder in the DSM are psychotic disorders. And our perception of schizophrenia, a psychotic disorder, is largely shaped by what we have seen in the movies. Is schizophrenia more than just a hallucination disease? In the 2002 movie A Beautiful Mind, which you've taken economics with me, I showed you a clip of with John Nash, a genius mathematician. He arrives at Princeton, befriends his roommate Charles. Charles is funny, charming, the two get along well. Spoiler alert here for you. It's very unsettling when later on in the movie, Nash is told that he never had a roommate at Princeton. He had a single room. Charles had been a hallucination, a symptom of the schizophrenia that Nash was beginning to suffer. Schizophrenia is known as a psychotic disorder characterized by patients who lose touch with reality, and that's what psychosis really is, losing touch with reality. It's more common in men than in women and tends to develop in men at an earlier age, between 20 and 28, while in women it typically develops between the ages of 26 and 32. Reasons for this gender difference in onset, as well as in brain structure and response to treatment, are really not that well understood. In the movies, these kinds of visual hallucinations are striking, but often overstated, representations of what it's like to live with schizophrenia. In reality, most patients, including Nash, do not visually see things. They experience more auditory hallucinations only, and though hallucinations may occur in any of the senses. I recently read an article about a young man who was convinced his neighbors were partying above him all the time. And, you know, if he banged on the ceiling or something, they would yell at him, call him names, that he could hear them talking about him. And, you know, a workmate saw how tired he was, said, man, maybe you should call the police. He called the police on these people. Police said there's really nothing they could do after speaking or going to the apartment, only to find out later that the people who lived upstairs had been on vacation or on a work-related thing away from home for months and weren't even there. And that's when you realize, you know what? There's something wrong with me. I need to go get checked out. And it turned out he was beginning to suffer from schizophrenia. So these auditory hallucinations are known as positive symptoms of schizophrenia, or symptoms that are more than what a normal person experiences. That's what we mean by positive. They're above, they're in a positive range. Hearing a voice offering running commentary on your behavior, kind of like the annoying director's commentary on a DVD, or hearing several voices talking amongst themselves are additional sensations that most people don't have. Other positive symptoms of schizophrenia include delusions, thinking you're someone you're not, thinking that the government is trying to take your refrigerator, and disordered thought or speech, which is what it sounds like, patterns of thought or speech that others can't follow or make sense of. If you watched the show on Netflix, Orange is the New Black, there was an inmate who had built a kind of cardboard house, wore tinfoil hats, certainly suffering from, delusions. She would, the way she rambled on when she talked, the disordered thought or speech, that was a certainly show I can't show in school because it's not very school appropriate in language and demeanor and depictions of sex, but very good depiction of what schizophrenia is like in that regard. But apart from the negative symptoms, there are also positive symptoms. There are also negative symptoms of schizophrenia, which are defined, not surprisingly, as symptoms that make a patient's experience less than other people's. And one of these is blunted affect, or emotions that don't seem to run the full range or experienced less intensely. Similar to blunted affect is anhedonia, or the inability to experience pleasure. Social withdrawal, lack of motivation, or other negative symptoms, though perhaps consequences themselves of a blunted emotional experience and inability to experience pleasure. So for example, seeing a relative that you adored and hadn't seen in a while, and your reaction is, oh, hey, glad you're back. That would be, some not only anhedonia, but certainly blunted emotional experience and ability to experience the pleasure of seeing this long lost relative. Some patients who suffer from schizophrenia actually stop speaking entirely, and this is known as alogia. Still others descend to a near catatonic state in which they are entirely unresponsive to the world around them. I mean, you prick their leg with a sharp stick pin, they don't even respond. Now, positive and negative symptoms appear in different balances across the 5 main types of schizophrenia, and we'll go through these 5 types. The first one is the paranoid type, which is what John Nash suffered from in A Beautiful Mind. It's characterized by mainly positive symptoms. The hallucinations and delusions tend to be persecutory, or in other words, the voices you're hearing tend to be singling you out and attacking you. Where the patient feels that he is very important, people are out to get him. And this type tends to have a later onset than others and a better outlook in terms of maintaining normal life activities. The disorganized type of schizophrenia is largely dominated by negative symptoms. A positive symptom, disordered thought and speech, accompanied by negative symptoms, emotional flatness, anhedonia, lack of motivation. The third type, the catatonic type, has patients either entirely immobile or in motion with no purpose. And these patients sometimes exhibit a really weird thing called waxy flexibility, which means they will not resist their arms or legs being moved and will then remain in whatever position they're placed indefinitely until they're moved back into something else. The fourth type, the undifferentiated type, are patients who have symptoms of schizophrenia but can't be classified into any of the other types. And lastly, the fifth type, the residual type, are patients who have positive symptoms but a very low intensity. So like most psychological disorders, schizophrenia has a variety of potential causes. There is a genetic component. If one identical twin has schizophrenia, the other who shares a genome has a 48% chance of having it as well. A fraternal twin of someone with schizophrenia has only a 17% chance of having it on the other hand. There is some evidence that too much of the neurotransmitter dopamine might contribute to the disease, as do certain brain structures like larger fluid-filled ventricles and smaller hippocampi. Now, on to the next classification, body dysmorphic and eating disorders. Most of us have things about our bodies we'd like to change. Maybe it's a nose with a small bump on it. Maybe it's hair that never lies flat. And usually these things that most people don't, other people don't notice about us, but that still bother us when we look in the mirror. I think I have a big ugly bumps on my nose, man. If I cross my eyes and look at my nose, I swear to God, I see these big ugly bumps on it. But if I mention this to friends, they think I'm nuts for focusing on it. And these little obsessions with our bodies seem to be an unavoidable consequence of owning a mirror. But sometimes this dissatisfaction with our bodies can turn into something more serious. Body dysmorphic disorder, or BDD, is a term used to describe a preoccupation with the body's faults to the point of getting in the way of daily life. People with BDD spend way too much time in front of the mirror obsessing about their problem feature and trying to find the best way to cover or distract from it. BDD is often associated with compulsive grooming, behaviors like picking at skin, plucking eyebrows, or combing hair. And in fact, this combination of body obsession plus grooming compulsion has led many therapists to treat the disorder similar to a more typical presentation of obsessive compulsive disorder, in which patients experience involuntary, intrusive thoughts and develop ritualistic compulsive behaviors to deal with anxiety. BDD is also associated with depressive symptoms and suicidal thoughts. Patients with BDD will often pursue plastic surgery to correct their flaw. And a recent Belgian study found that 43% of patients seeking nose jobs showed signs of BDD. BDD has gained more attention in recent years due to the fear that young girls are increasingly pressured by media images of models and celebrities to look perfect. There was even a reality show called The Swan that can be viewed as an unintentional public service announcement about BDD. It didn't last long because it had so many ethical problems. See, in it, ugly duckling contestants are given lots of plastic surgery and compete at the end in a beauty pageant which praises the best transformation. And we've all seen in the media people who at one point were very attractive people that went overboard with their plastic surgery to the point where they looked deformed, but they couldn't help it. They kept trying to get better and better doing it. Priscilla Presley comes to mind for me. So with plastic surgery so mainstream, it's easy to imagine that young girls might become more preoccupied with their flaws. Now, though BDD does exist in areas of the world where access to these kinds of images is limited, it does seem that looking at pictures of perfect women may be a trigger for those already likely to develop this condition. The media has also been suggested as a trigger for eating disorders. And these are related to BDD in that people with both kinds of disorders are obsessed with bodily flaws. Eating disorders are distinguished by specific behaviors towards food that are different than most people's. There are two main eating disorders, you may have heard of them, anorexia and bulimia. In both cases, patients take extreme measures to reduce weight, even if their weight is already normal or below normal. And you don't have an eating disorder just because you've decided to go on the Atkins diet. Healthy weight loss is healthy, and obesity is a real problem in this country. But just as a person with BDD might always think her nose has a bump on it or her knuckles are enormous, patients with eating disorders have an unrealistic sense of how much they weigh and how they look. Anorexic patients severely restrict calorie intake in an effort to lose weight. And people who are overweight and want to diet are typically advised to keep their calorie intakes above 1,200 calories daily. The average anorexic eats more like 600 to 800 calories a day. So just imagine trying to survive on this. For perspective, most burritos at Chipotle click in at 800 plus, and that's just one meal. Now, because it's really hard to eat so little, many anorexics develop strategies for tricking their bodies into thinking they've eaten more, cutting food into small portions, for example, or eating mainly vegetables like celery that are roughage and aren't easily digested by the body and so are expelled. Limiting calorie intake so severely can have serious health consequences, though. Being extremely thin can stop women from getting their periods. And since the body rightly judges that a baby couldn't survive on so few nutrients. Anorexia can also cause serious kidney and heart malfunction, dental problems, osteoporosis. It really can lead to death in extreme cases. In the past few years, there have been several prominent fashion models who have died from the disease, prompting the fashion industry to pass regulations to disallow models who are at starvation levels of thinness from walking runways. Once identified, anorexia is typically treated from several angles. Doctors focus on restoring a healthy weight while also treating psychological symptoms. Instead of limiting calorie intake, patients suffering from bulimia follow a cycle of binging and purging. In other words, they'll eat massive amounts of calories and then force themselves, usually finger in the back of the throat, to expel it, to throw it all up. Or they may take, heavy doses of laxatives to get it all out of their body. So they eat lots of food and then attempt to rid themselves of the calories by vomiting, abusing laxatives, or even exercising excessively. Again, exercising to burn some calories and lose some weight is totally fine and normal. But exercising for hours to entirely burn away the calories of a food binge enters into disordered territory. Bulimics are more likely than anorexics to have a body weight in the normal range, but suffer from medical consequences related to the purge phase of their disease. For example, all the acid coming up from your stomach when you vomit will erode and start to eat away at your teeth. Many end up with fluid or electrolyte imbalances or permanent damage to their stomach and esophagus as well. And like I said, some even have teeth that erode due to excessive exposure to stomach acids. Treatment for this generally includes psychotherapy as well as medications to help with depression and other psychological conditions. Eating disorders in general affect more women than men, though body dysmorphic disorders diagnosed equally across genders. Even so, some men, especially those with jobs that require careful monitoring of body weight, like modeling, but also certain sports like wrestling, jockeying, the military, do develop eating disorders and sometimes go undiagnosed due to their primary association with adolescent women. Nobody thinks to treat this in a man. So eating disorders are serious. They're often difficult to identify, and since the people suffering from them go to great lengths to conceal their problem, but not getting help can be dangerous and even fatal. So that's all I had for today for this. Do you guys have any questions? Okay, fair enough. All right, well, hopefully I'll see you back here tomorrow and we can keep talking about this.